Thank you very much, Dean Moore, for this kind introduction. Good morning, ladies and gentlemen. It's a pleasure for me to be here, and I have to confess it's the first time I'm here on the university campus, although I had driven by many, many times during the time I worked here in East Hanover, and I keep a great memory of my time in East Hanover. I loved New Jersey, despite every reputation New Jersey may have. And equally, it's a pleasure to come back to this area, but to the US in general, and I have many opportunities to do so. This morning, I will cover 3 topics, and I will focus more maybe on large topics of healthcare in general, what we're facing as challenges, and end with one comparison among several countries and how one may think about proceeding and thinking about this challenge we're facing on a worldwide basis. And of course, innovation is close to my heart, and I believe deeply that if we don't innovate, we will face even greater challenges than we anyway do. It has been said that Novartis does not only focus on innovative drugs, but also on generics. And maybe just one word of why we did this. First of all, we had a history of being in generics for a long time, but in a very focused area. And the question was in or out. Either you grow or you disappear, but you cannot stall. That is not a strategy. Secondly, the question was, if you're a patient and a physician, is there any incompatibility between patented, innovative, branded drugs and generics? And there isn't. As a patient, you can swallow both, and it will not create any problem. And you can write both on a prescription pad, and there's no problem neither. And I think there's a great legitimacy to really use the most cost-effective treatment. So innovation really is here, in my view, to give incremental improvements and occasionally even revolutionary improvements, but that's not so often the case. If we look at the major trends we are facing in the world, and that's no different elsewhere than it is here in the US, we see the number of individuals over 65 increasing dramatically. And if we would look at the over 80-year-old, it's also increasing. So a large demographic shift often linked to decreasing birth rate. The US obviously has immigration, which helps to keep a younger population. But in many countries, Italy, Spain, Germany, Japan, the birth rates don't keep up with the population, and populations are shrinking. The relevance in healthcare is obviously that after age 50, you tend to get at least one disease. In fact, when you're 80, only 13% of the population has no disease. And obviously that includes hypertension and very things we might not even consider as a disease. But many of us do have a condition after age 50. And so it's no surprise that if you look at the per capita spending per age group, it increases exponentially after age 55. So up to 50, roughly, it's relatively low, and then it becomes very expensive. If we take a third evolution, it's obesity. Here you see the chart where data started to be collected in 1985, and you see the blue ones, and that's all under 15%. 1990, more states measured, more states saw an increase in obesity. 1995, you see it's between 15 and 20% already. 2000, it becomes above 20%, above 25%, and some already over 30% of the population, and this is 2009. And so one can see the evolution of this problem, which is, of course, a disbalance between caloric intake and usage it's also a cultural issue because there are habits behind it. And it's very difficult to change these habits. But it has a big impact, and we'll come back to that why. And here you see how it's being projected. It's continuing to increase. And if you look at children, and the prevalence of obesity in children is increasing dramatically. You have many children with diabetes now already. And there might be a generation which lives not as long as we are supposed to live. If we look at the costs, we have direct costs which are estimated about 160 billion a year for this condition. But if you add the costs of individuals, you increase that bill already considerably. And you may ask, why incremental food expenses? It's very simple. If you're overweight, you need to eat more to maintain your weight. So once you lose weight, you need less food to maintain that. And that already says one of the problems. When you lose weight, you have to get used to smaller portions. And that's very difficult. And then if you add the cost to employees, absenteeism, presenteeism. Presenteeism is basically when employees are at work but not fully able to deliver. And if you add everything up, it's about 450 billion a year in direct and indirect costs. So that's a huge amount of money. If we look at the other frequent and costly diseases, cancer, hypertension, Alzheimer's, and diabetes, you can see where roughly, according to this study, the direct costs and indirect costs were in 2003. And here you see the projection in 2023. And basically, all of these triple in costs. And we think we are having a problem right now. We are facing a much bigger problem tomorrow. So that raises, of course, a big challenge. And the US sticks out as a spending per capita and also as a percentage of GDP, but all countries see increasing costs. It's everywhere around the world. And what one can also see is that in the developing countries, in urban centers, you see the same changes in pattern in the diseases we're seeing here, cardiovascular, basically diabetes. If we look at the current financial crisis, and we put the crisis we see today in perspective to two which were very costly and considered as huge in the history, the Marshall Plan and the New Deal, you can see how much bigger the dimension is today. And if we look, and that's illustrative, but if we look what the debt-related costs are for public spending, and we add the new debt which has been added, and we look at how much money has now to flow in paying for that debt, it's easy to understand that the money which remains for budgetary expenses, among others healthcare, will decrease. So it's no surprise, and probably you have seen now talking about increasing the age for Medicare to 69, I think. And France tries to do it to 60, but everybody is on the street protesting, so I don't know. I don't want to give you bad ideas, but anyway. If we look at our industry, the pharmaceutical industry, and how we understand our role in society, it has to be to reduce mortality, to reduce morbidity and suffering, be cost-effective, and at the same time profitable. In the market system we are in, obviously, if you are not profitable and competitive, you will disappear. And the question, if we're effective in doing that, is very difficult to answer when you look at very short periods of time. But if you compare diseases and their mortalities in the 60s and today, you see suddenly huge differences. I mentioned a few here. And for example, ulcer of the stomach or duodenum at the time were basically just treated by antacids plus minus, and then surgery. And it had considerable complications. And today, very few people have to undergo surgery. You have the proton pump inhibitors and other medications. Ischemic heart disease, Infant mortality decreased massively. That has a huge impact on mortality. But also if you look at COPD or asthma, you would see a big decrease in mortality. In cancer, today we have 65% of the patients over who are adults who can survive over 5 years. And that's up from about 50%. The more dramatic impact you even see in children, where the mortality has been cut in half in the last 25 years. So there you see the progress in diagnostics, in care, and intervention has been quite dramatic. And with that, of course, and that goes back to my first slide, the life expectancy is increasing. And luckily, not only the life expectancy, but also this is combined with a decrease in long-term disability. And that means we don't only live longer, but we generally live better. And obviously, just living longer wouldn't be an objective. Another confusion one sees often is that pharmaceuticals, not only in the US, are being seen as extremely expensive. And I have to admit that the increases in pricing has been inflationary and, in my view, not always justified. The overall part of the pie, however, is relatively low. So if we look worldwide, it's between 10 and 20% in general. It's also interesting, we just recently did a study in Switzerland of the population, what they estimated. They thought in average about 35%, while it was only 10.3% of the overall bill. So the belief that pharmaceuticals are a major cost driver is deeply rooted. And of course, it has to do with the press and the coverage and about what we're talking about. In many countries, the hospitals are the biggest cost driver, also in the US, but the proportion in other countries is about 50%. Here it's 31%. And I think it has to do with a push which occurred a few years ago to take the patients out of the hospital into ambulatory care. So the piece of ambulatory care has increased, but of course much less than it would have increased if people would have stayed in the hospital, because the infrastructure costs are just very dramatic. And more interesting is the question, do drugs add to the bill or do they reduce systemic costs? Because of course, if you want to do a proper analysis, you shouldn't just look at the different segments of the cost treating a disease or a patient, but you have to look at the integrity and how the different elements of a treatment are being influenced by an intervention. So is the disease shortened by a hospitalization? Is it shortened by a drug intervention, by a surgery? And to what degree? And what does it add and diminishes as costs? And here you see one study from 2008, but there are several studies basically showing if you prescribe rationally, if you take your drugs in a way which corresponds to evidence-based medicine, you will save costs overall in the system. So it's cost effective. Now, if we look at innovation, and there have been many, many different technologies which have come to light in the recent years, and of course the uncovering of the human genome has created a huge expectation. And I think in every new technology and fundamental progress, one can think faster than one can implement. So one can deduct and anticipate what can happen, but in order to make it happen, there's lots of steps which have to occur. So there are gestation phases of new technologies until they reach really maturity and will impact the practice of medicine. And that's generally between 10 and 20 years. It's not shorter. And I think that we will see major impacts of the progress which has been achieved scientifically in the last 10 years, but it generally is followed by disappointment. So first it's a euphoria, overly optimistic, then it's overly pessimistic, and then reality kicks in. I will not go into all of these different technologies, but just talk about pathways and what we understand under pathways. Pathways, in a certain way, are the language in the body, the language between different cells, different organs, and within a cell itself. So how does a cell know what to do? How does an organ know what to do? And how does it communicate, and what networks exist? They are highly complex networks, and of course the most complex one is our brain. But what we can do today by combining different technologies, and informatics have played a very central role here in order to really be able to process all this data, we can identify nodal points in these networks. Where does one intervention influence specifically a language? You can imagine by saying, I will not do this, and you delete the not, I will do this, has a completely different meaning. This is not very different here. So it is really the question, where can you intervene in activating or blocking a pathway to change the pattern? And one example is the MTOR pathway, and you see here different steps of that pathway. And one, this MTOR, one, if you block it, will influence cell growth, nutrient uptake, and angiogenesis. These are all factors you can easily imagine which are important in tumor growth. And so if you block this pathway and this mTOR receptor, then you can influence tumor growth. And we have one drug which does that. And we tested it in various cancers. It is approved, meantime, in metastatic kidney cancer. And you see in the upper right how the cancer from the right to the from the left has evolved to the right, basically shrinking. But also certain types of breast cancer, mantle cell lymphoma, and gastric cancers have responded quite well. And the belief is, obviously, it's not a monotherapy, but it's an addition to other therapies. And it's relatively well tolerated. So I think it will become an important cancer treatment. We just received also the approval of a disease which is, for a disease which is not very frequent, tuberous sclerosis, but has a very dramatic evolution for these kids. They have cancers, they have epilepsy, and we have seen that they have an hyperactivation of that receptor which can be blocked, and the evolution of the disease is much, much better than without the drug. It's the only drug which works. By the way, this is something we are trying to do with many of our new compounds to find a disease which is as purely representing a certain pathway as possible, and then testing the hypothesis, the proof of concept in humans. And then if that works, we will branch out in bigger indications. A few years ago, we have launched Gleevec, which was or still is, a highly targeted therapy on a protein which generates or tells the cell to divide and grow. And when you block it, you block basically the growth of the tumor, chronic myeloid leukemia, and a GIST tumor, a gastrointestinal stromal tumor. And we see that 95% of the patients survive 5 years and do quite well. However, Gleevec also has been linked to some resistances to the drug. And our scientists looked at the structure of the receptor and the drug, and if the drug really fits perfectly well the receptor. And it doesn't perfectly fit the receptor. So what they did, and you see the difference between the left and right side, that the new drug they synthesized fits perfectly well. And then obviously the discussion was, well, can we even beat the numbers we have produced with Gleevec? And there were many doubts if we should even invest in that, because it's a very difficult standard to beat. We did it, and in fact, the Cigna beats Gleevec, also in complete remissions. And so we have now a new drug for first-line therapy, which seems to be even better than Gleevec. However, there's another problem which still exists. We have probably stem cells, which are neoplastic stem cells, basically pre-cancer cells or cancer cells, which are quietly sitting somewhere, and when you stop the therapy, the cancer comes back. So it's not a cure in that sense, but it's just suppressing the growth of the cancer. And we know, for example, in breast cancer, that women with breast cancer who have been treated and have been cured, you don't see anything for 5 years, 6 years, 7 years, 8 years. Suddenly in year 10, there's a reoccurrence. And when you examine the genetics of that cancer, which is either new or the old one, you often see that it's the same genetics as the first one, which enhances this belief that there might be cells which just remain dormant until there's a trigger point. So the question is, are there receptors which could suppress these stem cells? And we believe that the Hedgehog pathway, that's another one which has been described, possibly could suppress these cells. So we have developed a new compound which blocks this Hedgehog pathway, and maybe if we combine it, we can come to a cure. I'm telling you all of this because it shows you how the evolution of a treatment occurs. Philadelphia chromosome, which has been discovered in the 60s, was basically the basis of understanding the molecular basis of CML, of chronic myeloid leukemia. So you have the discovery of a chromosome aberration, and then you have in the 80s the molecular basis, what happens in the cell based on that translocation. And then again 20 years later, you have a therapy. So the basis, the scientific basis often takes quite some time until we see the consequences. Now, healthcare reform. I'm often asked, well, what should countries do? And obviously for me, it's extremely difficult to give any advice which will look objective, because people always think, well, he's talking for his own church. And so I'm a little bit tinted, but nevertheless, I would like to share some data with you and let the data talk rather than me. These is the data showing Medicare spending per beneficiary and the average outcome, the quality of the healthcare. And you can see that certainly there is not a linear correlation between higher cost and higher quality. Quite the opposite. It seems that you have in the Northeast lower costs and higher or better quality. And in the South, you seem to have a lower quality and higher costs. These are publicly available data. And I just wonder why never anything is being done about it, because within the same country, you have huge differences in quality and costs. And one would argue you should find out why and correct the situation. So we asked ourselves, how could one understand better what makes sense and what doesn't make sense in treating patients? So we looked at the so-called DALYs, impact of a disease on disability or death on life, per 100,000 people. And then we look at the same time what are the costs of treating these patients. And you multiply, and that gives a certain productivity factor. So you take, as an example, the disease burden in diabetes type 2 in the UK. You have per 100,000 people, 232, and in the US about the double of persons who have diabetes. Then you look at the costs. In the UK, it's about 2,500. In the US, it's about triple, or a little bit short of triple, over $6,000 per patient. And then you multiply, and then obviously if you take UK as one, then you have a 4 times 7 higher cost in the US than in the UK. That's all good and nice, but now you have to understand why the heck is this difference occurring. And then you cannot stay at the surface anymore. You have to drill deeper. We did, first of all, the analysis on various diseases: diabetes, COPD, hypertension, stroke, and breast cancer. And we looked where the leaders were, best practice basically, and where the laggards were. I give you just two examples here. In stroke in Switzerland, we were leaders. The factor which turned out to be absolutely crucial and the most important one within a country and among countries is the density of the hospital system, where somebody with a stroke could immediately be treated to basically dissolve the clot. And if you're far away from a hospital, basically the time is so short for intervention that it's too late. In breast cancer, in Switzerland, we are laggards. And within Switzerland, you have huge differences. And if you look why, it's only mammography, and basically prevention. So that is the only difference. And then the second is aggressive therapy, once you have a diagnosis. And so the US here is leading and is much more cutting edge in that disease than any other country we have examined. COPD in France, they are very systematic in using, for example, measuring with spirometry and then intervening. And if you then look what you could gain in productivity, it's quite dramatic. Here, it's basically detailed what the differences are, and you see how strict they are in following guidelines. So if you ask what is needed in order to progress, we need transparency, data transparency, which also means that we need standards of measuring. You cannot measure 50 different ways and then comparing. It doesn't work. We need protocols which are evidence-based, so that we really use treatments and diagnostics in a way which is demonstrated to be rational and to be effective. And if we look at the universe, especially if we have multimorbidity, polymorbidity in aged senior people, in higher aged people, then obviously you need integrated care. What happens often is that people are being sliced into different pieces, like a motorcycle between, different mechanical. So people are looking at human beings as mechanical pieces. We are not mechanical pieces. We are an integral, entire human being with a psychology, an environment in which we live, and with our bodies. And so the integral view and care is very important. And finally, if we do not align incentives accordingly, there will nothing will happen. I give you two examples. In the UK, if you're 17 and you go to your GP for the control and you are overweight, he will measure anyway the BMI, your body mass index. If you're over, immediately he will advise you on diet and exercising and everything. He is being paid for you not to become sick. On complications for the eye, for the kidney, he will look at your complications. In the US, we would be paid for treating you with the complications. So the incentives are really very different. And unless we address that topic, we will not see a change in practice. The second example I give you is that here we have, of course, a litigation system which is very costly. It's estimated about $200 billion per annum for defensive medicine, insurance cost, litigation, and of course, most is leaked into the system and is never reaching the patient. And if we could change that to limit this basically system, judicial system, it would be a big savings. I talked to a president of a large US hospital and I said, surely must be in favor of changing this, and you surely lobby for it. He says, please never quote me, but, and I won't say his name or his institution, he said, but, you know, we make our money with diagnostics and drugs. If we had no diagnostic sales and drug sales and the profits out of that, we would be in the red. So if then you have the lawyers, diagnostic companies, pharmaceutical companies, and the hospital administrators who are all in favor of the current system, guess what it will happen if somebody tries to change it? And nevertheless, I think we have a duty to really make sure that we do the utmost in prevention, that access is guaranteed, quality and sustainability from a financial point of view. My only point is, if you look at the current healthcare reform, access has been addressed, but not quality. And of course, if you only change access, the costs will increase dramatically. And the only way we would address, for example, in the company, a cost issue in a factory where the quality isn't right, you don't go and address quality by cutting costs. You first have to pour in sometimes more money in order to understand the problem and to fix the problem first, and then you go at costs. And I don't think the current trajectory is very promising. Nevertheless, I think, and I'll close here with a quote from Michelangelo, the greatest danger for most of us is not that our aim is too high and we miss it, but that it is too low and we reach it. Thank you very much for your attention.
Thank you very much, Daniel. That was very informative, very interesting, very, I guess, frustrating for our healthcare system. A little bird told me that Daniel was in the Bronx recently at a university, and he wasn't challenged with enough questions. So I'd like to show him that on this beautiful campus, we can challenge him with a few questions. I'd like you to keep the questions short so we can get as many in as possible. I will start with an easy question. As a European citizen, not the leader of a Swiss pharma innovation company, what country should we emulate if we were to do healthcare reform properly?
I don't think I would emulate any country because you need to be yourself and you have to take into consideration what your starting point is. But I think I would learn from other countries. I would go where the best practices are by country. The problem is if you try to fix it by political system, you miss what medical practice is. You have to start with medical practice and then implement the policies. So I would argue I would take it step by step and not thinking that with a big new legislative overhaul you can fix it.
There's been a lot of commentary in the press regarding a lack of productivity in regards to R&D. Would you just comment on that, please?
Yeah, I find it as typical as often you get these fashions. You get the fashion of be ultra-focused, then no productivity in R&D, then you have a next one. So I don't give a lot about that. But if you talk about productivity, you have to ask, is the output lower? The number of new approvals is not really lower. In the last 40 years, if you look, since 1960, I looked at the approval rates. There was one peak where we had more, but that was the working off a backlog at FDA. But otherwise, it's pretty stable. What has changed really is the costs of R&D. They have increased again and again year after year. I don't know where it stands, but I would estimate about 1.82 billion a drug. There are big differences between different drugs, but if you take into account all the failures, it's probably quite accurate. Now, of course, if you talk about productivity, you have to take into account the costs, and then productivity went down. But I think the implication is more, the industry is not able to bring new drugs to the market. in my view, is not true. The fate of different companies is a little bit different. There are differences. And the fact when we had the introduction of generics and adoption of generics, which make up more than 70% of the market today, volume-wise, and you had this abrupt fall, companies who used to survive on older drugs just couldn't. In the second row.
Would you, I was interested to hear you say about changing medical practice or looking at medical practice. Could you offer any commentary on medical education and paramedical education and residency, your thoughts to improve that process?
I'm not as familiar as I used to be. When I was practicing, costs didn't play any role. We could prescribe what we wanted. We could do the tests we wanted. We didn't know what it cost. And when I left, they started to print what the test cost. So, but this was just the beginning. And meantime, I think we're already rationing. So we are seeing a rationing of medicine in many places around the world. If you would ask me, I think in this question of integrated care, to understand the patient better in all facets and how to work together as a system, I think would be important. I also believe that how can we basically treat patients in a remote way? What are the technologies which can be applied and still be personal? Because the human interaction is important. How can we unfold that? I think would be an important other aspect. There are more people who are more suited to answer this question than me. Please.
I would like to know exactly how you see the sourcing of scientific innovation. And we very often speak about innovation in terms of scientific innovation. But personally, I would like to have your feedback on how you relate this scientific innovation with the cultural innovation of work processes, workflow, and approaches, without which I believe the scientific innovation is not really leveraged. So I'd like to know, what is your thing? Where do you see the main sources of innovation to be as far as R&D? And what is the Novartis approach to leveraging this innovation through culture and process?
We have changed in several ways the way we have the physical environment. So we have gone from individual offices into open plan offices with it's called multi-space. Why multi-space? Because we will have a corner where people can sit and have coffee, another open space where they work, and trying at the same time to keep intimacy. And it's not cubicles. Don't misunderstand me. It's open, much more open. And also to have a communication between different levels of a building. So not just on one level, but among different levels. And we just recently opened what we call the Lab of the Future, which is obviously a buzzword, but what it says is we have intermingled chemists and biologists who were previously separated in one and the same open plan lab. We had to overcome a lot of barriers with regulators because of safety measures, but we were able to persuade them. And the working space is also mobile. So it's flat open and you can move stuff around depending on the needs. We have a communication tools, basically touch screens, where you can directly punch in what you have on the lab in the lab books, and you can directly interface with the people in the labs in the US, in Cambridge or Shanghai. So Basel, Shanghai, and Cambridge are being linked, and you can talk to each other, basically. So using the new IT communication tools in the labs. Now, these are only tools and environment. Then, of course, you ask yourself, well, what do you do? And our desire is to create an environment where people feel comfortable, like it, while not making the mistake. This is not a club, it's a workspace. You know. But we have dismantled the canteens in Basel, and it's all small restaurants, an Italian restaurant, a Japanese one, and Mexican food. So it's much more like a small village or a city. You can shop on campus. So also thinking of people where both spouses work. And we are opening now a child facility, which is just at the border of the campus between the inside and outside. So the parents can take the kids at noon inside the campus. Because frankly, I went once to Harvard Business School, and I looked for a room, and I got lost. And so I ended up in a room where there were families with the kids, and they were listening to music and drinking something. And I thought, wow, how wonderful. Why can't we do that? So when I came back and I proposed it, they said, well, but we have, you know, manufacturing, it's dangerous, liabilities, and all of that. But frankly, you know, so you have sometimes to break some barriers and do that. I think it's not just what you implement, it's also what you signal with it. So for the better or the worse, that's what we are doing. And then, of course, sourcing, it's not just internal, it's external. So it's collaboration with hopefully the best universities and academic institutions and biotech companies. And it doesn't matter from where an idea comes if it's a good idea. And I would say the patent system allows us, luckily, to share insights without having to fear that it will be stolen. And secrecy is no alternative. So I really think this patent system, which exists since the 15th century, invented in Venice, really has proven to be a very effective and good system.
Hi. I'm wondering, a lot of healthcare nonprofits, they mention that their ultimate goal is to be out of business. So for example, the American Cancer Society, they imagine a world where cancer is eradicated, and so therefore they wouldn't have to exist. And so I'm wondering, you had mentioned preventative medicine and incentives need to be changing so that we can take care of the people instead of take care of the business. And coming from a pharmaceutical executive, it's refreshing to hear that, first of all, so thank you. And second of all, I'm wondering, what do you see the role of pharmaceutical companies in the future if the goal is really to prevent many of these diseases that we see today?
I mean, if you look at the evolution of industries, there are industries which are not needed anymore today, which were essential 100 or 150 years ago. Just think of the arrival of the car and combustion engine, you know, what it did to the horses. And if you were in the horse business, I mean, you can survive with some exotic horses, but not in the carriage business is probably not the best one to remain in. So I think, you know, as society changes, industry will change. I'm unfortunately not worried that we will be out of business for a lack of need. There will be ongoing a lot of need, I have no doubt. Front
Yes,
row? And
yes, thank you. Andrew Welton, Science First in New Jersey and Johns Hopkins Medical School, Baltimore. First, thank you for that, I thought, absolutely wonderful and inspiring overview. It really was superb. And I think we're all very appreciative of that. My question to you is, as you look back on your personal experience, the schism that exists between a federal government and federal regulators vis-a-vis the evolution and development of new drugs versus the drug industry. The drug industry are always portrayed, or typically, as the bad guys who want to make a profit for their shareholders. But innovative drugs literally never come from a federal funded source. Yes, studies will be done to assess public health implications of existing drugs funded by, for example, NIH in the US. How do you see the melding of this schism? This seems to me a constant obstacle to development of drugs and the acceptance of the innovation in the public health arena.
I agree with your observation. I think there are multiple reasons for that. First of all, let's not forget we didn't have a drug benefit in the country, and people felt how much they had to spend for drug treatment out of pocket. And that was really, very difficult for some people. And the prices for some treatments are really very, very high, to say the least. That is an objective, fact. Secondly, if you look at studies, I looked at a study, The Value of Things, I think it was called, of the 80s, and it examined how would the general public value what they get for $1. And it went through all kinds of things, food and, clothes and living and drugs. And interestingly, poultry was at the top. They felt they got most out of the $1 for poultry. But pharmaceuticals were very high up. And legal services were relatively low. We joined the legal services meantime. And however, it's not as bad as some people think. So when you do these surveys, we are in the bottom third, but at the top of the bottom third. So there are a number of things which are lower. It's interesting, today nurses are very, very high up, nursing. And so the perceptions change. There's another thing which I think has an influence in the last 20 years it has changed. Today we're in a society where aggression is positive. You need a villain, you need a vindicator, you need somebody who is the good person. And that is a scheme we see in many, many areas, and pharmaceuticals is no exception. There is also, that's a theory, a hypothesis, but at least I'm asking myself, when you make money and you see pharmaceutical companies making a lot of money and the executives making a lot of money, then you're a government employee and you make little money. So automatically you think, I make little money, but I'm a good person. He is making a lot of money, but he's a bad person. So the schism is also in this kind of own image and perception of others. So it is going deeply into society and psychology. How do you bridge it? I think we have to fulfill the social contract in some way we have, which is to bring ever better treatments to patients. If we are able to do that, I think we will continue to exist. The day we stop doing that, we will stop to exist. That's fine. Yeah.
Thank you, Dr. Vasella. You mentioned the importance of the patent system. Can you say something briefly about attacks on intellectual property globally? Thank you.
Yeah. I would say in the US, the attack is mostly from the generic companies, where it sometimes pays more to attack a patent, to infringe a patent, and then find a financial arrangement to fix it, than not to attack. And that's a perversion in my view. So I think we should have a system where the patents are really protected. Once the patent is gone, then it's fair competition. But I could share with you stories where, basically generic companies would make a settlement and say, well, we'll only sell what has left the company. But they had truckloads parked outside the company ready to roll. So all kinds of tricks. Completely different in China. It's starting now to be more respected. But China is a big country, so in the Western areas, you still have some infringement going on. But when we have a problem and we communicate with the government, they always take care of it. So I cannot complain. India is again a different situation. India has implemented with following WTO a regimen, but they are so tricky that they can circumvent it at the same time. So, and it's very legalistic as a system and very bureaucratic. So that will take time. But if you look 100 years ago, countries like Germany and France had patents, Switzerland had none. And guess why Basel was such a good place to be? because you could take innovations and you could, basically without patents, you could go and copy. And so once countries are going up in their potential to innovate and with the capabilities of the people, they start to protect their own inventions. And that's happening in China very visibly, and I think it will happen in India.
In terms of driving systemic global change in priorities around healthcare, I'm wondering if you have any thoughts on the many efforts underway to fundamentally redefine GDP, which, as you know, basically devalues caring and life-giving support, such as Hazel Henderson's work, Rianne Eisler's work on creating a caring economics, her book, The Real Wealth of Nations. So, however difficult it is, and I do realize it's difficult, we created GDP. And do you think if we change GDP, that could be a huge driver and lever to shift our global priorities?
I don't know. I apologize, but I cannot answer your question. I don't know.
Thank you. You clearly explained how innovation takes a lot of time. So how Novartis is, or how innovation is affected when you deal with acquisitions and consolidations with other companies bringing to Europe?
Yeah, every acquisition and integration is an adventure in itself, because obviously there's a lot of psychology going on in both the acquirer and the company who's being acquired. If it's very clear-cut, so it's an absorption, I think it's a question how credible and how well can you articulate what the upside will be to join the new company. So, because people generally, especially if you're longer with a company, you have a certain identity which is linked to the corporation you're working for. And you have to give up this identity and accept another one. And unless you see advantages in doing so, it's very difficult. So you have to have attraction to join. If the two are relatively of the same size, and if that is not clearly spelled out, how you are going to address it, very often for years you have resentments on both sides. And I've seen both examples. That was one of the reasons why we did neither choose Sandoz or Ciba as a name, but we said it was wonderful. Both entities were fantastic, but we're building something new which goes one step further. And that allowed people to let go a little bit more. But I have also to add that many people left and new people came and joined. So you have, of course, a overall change. In R&D, we did not see really a decline, but it had to do also with the fact that R&D for us is being recognized as being central to our business. And we had maybe less the desire to absolutely have blockbusters and to be on this marketing model, more on the innovation model. And I think up to now it worked. You know, you never know, because there are, of course, investments, there are people, there's luck. And so you need all good ingredients. Maybe a last question?
In fact, I'm going to be selfish and take it. And I'm going to ask you on behalf of one of our board members, the head of economic development in the state, and by extension our governor, how can New Jersey, this great state, be a better partner for Novartis, for the pharmaceutical companies in general, as we enter this innovation age where there's so many towns, cities, countries competing to be the next innovation hub or hotspot?
If I look at the clusters we have in the country, I do really believe that science plays a major role. So that's the reason why you see in the northeastern corner around Boston, Cambridge, you see a hub. And you see in California another hub. Maybe South Carolina or North Carolina in the research triangle, but it's already a little bit more shaky. New Jersey, in my view, has not succeeded in establishing the scientific excellence which we see in these two other parts of the country. I think that would be one area. And of course, you compete with New York and you compete with Boston, but that is something which I would think is important. Secondly, you cannot have an adversarial relationship with so important stakeholders as the pharmaceutical company here in the state. You have to demonstrate that you support the industry. And you have to ask, why does anybody rather stay here and implant themselves here than elsewhere? And then you come to taxes, you come to bureaucracy if people want to invest, and so forth. And also basically the talk. And so I am surprised, or was surprised in the past. I haven't followed it very closely, but I have been surprised that occasionally I felt strange that a state who lives so much from this industry is not more friendly to its industry. And is that really smart? I don't know. So all I would say to government is, we are listening. Thank you very much.
Thank you very much.
Thank you, Jim.